On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Kelly Zucker. Dr. Zucker is board certified in both gastroenterology and internal medicine. She specializes in colon cancer screening, motility, inflammatory bowel disease, otherwise known as IBD, liver conditions, and esophageal reflux or GERD. Dr. Zucker performs a large volume of gastroenterology procedures, including colonoscopy, upper endoscopy, video capsule endoscopy, pH testing, and hemorrhoid banding. Dr. Zucker sees patients at Gastroenterology of the Rockies in Boulder, Lafayette, and North Glen. Welcome, Dr. Zucker.
Good evening, and thank you to those of us who are joining live and who will be watching this later on. My name is Dr. Kelly Zucker, and I am a gastroenterologist working at Gastroenterology of the Rockies. Tonight we're going to be discussing colorectal cancer, the preventable killer. A little bit about myself before we get into the lecture. So I went to college at Grinnell College in Iowa, and I earned a bachelor's in arts in biological chemistry. From there, I went on to medical school at Western University of Health Sciences, College of Osteopathic Medicine of the Pacific Northwest. After medical school, I served in internal medicine residency at the University of Arizona in Phoenix. I was voted by faculty as the intern of the year in my first year of residency, and in my final year of residency, I was voted by my peers as resident of the year. I also served as the House Staff Council president during my final year of residency. After that, I then went on to Gastroenterology Fellowship, also at University of Arizona, Phoenix. I've had multiple research projects, publications, and have spoken at national conferences, mainly in liver transplant outcomes. During my fellowship, I was also a visiting fellow with the National Motility Society, so I learned more about esophageal motility. And in my final year of training, I was the chief fellow of the Gastroenterology Fellowship. Tonight, we're going to be talking about what is colon cancer, how does it develop, how can we detect and or prevent colon cancer, and we'll briefly discuss some of the higher risk groups for colon cancer. So March is the Colorectal Cancer Awareness Month. In 2000, President Bill Clinton officially dedicated March as the National Colorectal Cancer Awareness Month. And in Colorado in 2019, Governor Jared Polis signed a proclamation declaring March the Colorectal Cancer Awareness Month in the state of Colorado. And you may have seen at the Empower Field in previous years in March that it was lit up blue for colorectal cancer awareness. So colorectal cancer is very common. There's multiple people that have been well known in the media that have been known to have colon cancer, including Pope John Paul, former Justice Ruth Ginsburg, Chadwick Boseman's been one that's been more well known lately due to his young age, as well as Charles Schulz, Jackie Gleason, Elizabeth Montgomery, and many others. In my own family, both of my grandfathers did have colon cancer, and one recently passed away from it as well. So colorectal cancer is the result of a sequence of biologic events, and things that we're really going to touch on tonight include that it is common, it is lethal, and it is very preventable. Before we begin on what is colorectal cancer, let's show a diagram of the colon. So the entire colon is approximately 4 to 5 feet in length, and it's divided into the major segments listed on this diagram. Now, in reverse order here, we have the rectum, which is where stool is evacuated, followed by the sigmoid colon, then the descending colon, the transverse colon, and the ascending colon, followed by the cecum, which is where the appendiceal orifice is and where the large bowel and the small bowel meet. A colonoscopy, which is colorectal cancer screening, which we'll talk about more later, will see the entire colon, also known as the large intestine. So it'll see that entire 4 to 5 feet. Now, with colorectal cancer, the signs and symptoms that we would worry about and would warrant further discussion include blood in the stool, changes in your bowel habits, particularly constipation, changes in the shape or the size of the stool, rectal pain, abdominal pain, unexplained weight loss, or new or unexplained anemia. When a colonoscopy is performed, we are looking for colon cancer or precursors for colorectal cancer, which is called polyps. Gross appearance of a lesion during a colonoscopy cannot reliably tell you if it's a certain kind of polyp and sometimes even cancer. Therefore, whenever you have a colonoscopy, we will biopsy or remove colon polyps or abnormal tissue. And here are some photos of colon cancer and colon polyps. And so as you can see in the top left, this is a larger lesion, a lesion that is bleeding, a lesion that is taking up more of the colonic wall. So this is one that's more suspicious for potentially a colon cancer, versus in the bottom right photo and the top right photo, these are smaller polyps. They're not completely occluding the lumen of the colon, and they can be easily removed with one forceps or with one snare from the colonoscopy. So these are more likely colon polyps, but we don't know what kind of polyp, and we don't know for sure that there's no cells of colon cancer until it's removed. And this one, as you can see in the bottom left, this one is a little bit more obviously a colon cancer. It's taking up the entire lumen of the colon. It has blood vessels feeding it, which is why it has that more purplish hue, and it just looks a little bit more aggressive overall. So most colon cancers will arise from adenomatous polyps, and those can progress from small to large polyps and then into a colon cancer or colon carcinoma. On average, it takes about 10 to 15 years for a colon polyp to progress into a colon cancer, and that's why for the average risk patient, you will never have a recommendation to be more than 10 years between colonoscopies. And very often, a lot of these patients will have colonoscopies recommended at shorter intervals due to either personal or family history of polyps or cancer. One thing to note with colon polyps, not all colon polyps will turn into a colon cancer. It's probably about 10% of adenomas that will become cancerous, but of the types of colon cancer that have been found, 95% of these colon cancers have arisen from an adenomatous polyp. So when we see a polyp, we will take it out because we can't let you know for sure if that one will or will not become a cancer. I like to compare this to moles. You have many, many moles on your body. Not all moles will turn into a skin cancer, but some might. And since you can visually watch and track those on your skin, you may not remove all of them, but in the colon, we can't watch them as regularly. So we are going to take them out and eliminate any threat if we can. So here's a couple more photos of different types of polyps, just so you can see some of the things your gastroenterologist will be looking for during an exam. In the top left in figure 1, that's called a hyperplastic polyp. That is one of several types of polyps. That is a non-precancerous kind of polyp. As you can see, it's fairly small, but it does look similar to some of the other polyps on the screen. So if we see it, we will most likely take that out. In the second figure, that's called a tubular adenoma, and that one is what's called pedunculated, meaning it has a little stalk. It's not completely flat and flush with the colon wall, and it's a little bit raised, and it's another one that we would remove. As you can see in figures 3 and figures 4 and 5, sometimes the polyps will grow and spread in a little bit more of a lateral fashion, and sometimes they will have even more of a stalk. And then figure 5, this one actually has what's called high-grade dysplasia, which is a more suspicious and highly more likely precursor to colon cancer, but hard to tell figure 5 from figure 2, which is why we will remove them all. Additionally, just for some more photos of what we're looking for during a colonoscopy, as you can see, some polyps are very subtle. In figures A through F, these are much flatter polyps. They're not really raised. They don't have a stalk. These can be easily missed during colonoscopy, particularly if you have poor prep, because as you can see, if there's any stool or any liquid overlying the walls of the colon, these flatter polyps may be missed. And that's why not even a colonoscopy is 100% effective at detecting colon polyps, but it is overall very good, particularly if you have an experienced endoscopist. And these are just 2 more photos, and these ones are colon cancers. So the figure on the left is very similar to one of the first ones we saw when we went through the photos. As you can see, it's ulcerated, it's bleeding. Overall, it just looks like a much more aggressive tumor. And then the figure on the right, this one is a colon cancer that has grown in a circumferential fashion around the entire wall of the colon, leaving only a small opening in the center. And that's why a lot of times we will ask you about the appearance or the diameter of your stools. Because if your stools become really small and pencil thin, that's often because they're squeezing through something like this. They're squeezing through a narrow lumen because something hasn't closed off the normal diameter of the colon. Now, colorectal cancer is very common. This number can change quite a bit depending which source you look at, but overall, globally, it is the second most common cancer in women and possibly the second or third most common cancer in men as well. And it is the 3rd or 4th leading cause of overall cancer between men and women. And again, that varies just a little bit based on which source you're looking at. There's roughly 150,000 Americans diagnosed with colorectal cancer annually, and it is pretty lethal. There's about 50,000 Americans that die from colorectal cancer, which is about 8% of all cancer deaths. And as we said in our earlier slides, one thing to note is it is very preventable. Colonoscopy aids in localizing polyps and precursors for colon cancer, and we'll get into this a little bit more later on in this presentation. So looking at the incidence of colorectal cancer over time, so there's some good news and some bad news. The incidence of colorectal cancer has decreased 40% since 1987 in patients over age 50, and that's due to the advent and the advancement of screening modalities, particularly colonoscopy. Colonoscopy has much higher definition colonoscopes than used to be available in the previous decades. There's also more colonoscopies performed, so endoscopists are becoming more skilled at finding, removing, and eliminating any threats as we're able. However, we are seeing an overall increase in colorectal cancer in those under the age of 50, which is why several years ago there was a push to decrease the screening age of colonoscopy to 45. Previously, it had been age 50 for a very long time, but now 45 is the new recommended age to begin colorectal cancer screening. Now, there's lots of theories of why there's been that uptick in younger patients getting colon cancer diagnoses. And the most common thought is it's related to unhealthy diets, primarily processed foods, and then a more sedentary lifestyle. Now we're going to discuss some of the colorectal cancer risk factors. So a risk factor is anything that will raise your chance of getting a disease such as colon cancer. Different cancers are going to have different risk factors, but having a risk factor does not automatically mean you will get the disease. It just means you may have an increased chance of developing this disease sometime in your life. For colon cancer, we know demographics such as country of origin, age, sex, race, diet, and family history can all change your risk of colon cancer, and some of these can put you at higher risk of developing colon cancer. Of all of these demographics, by far the highest risk comes from a family history of colorectal cancer, and we will discuss that a little bit more later on in this presentation. Which will actually be right now, never mind. So the lifetime risk for those who are an average risk, meaning you have no family history, you have no genetic or inherited conditions, you have an average risk of about 5% for developing colorectal cancer. Now, if you have a family history, that risk can increase quite a bit. So that risk is considered higher in those who have first-degree relatives with colon cancer, and then the more first-degree relatives or the younger those first-degree relatives are, the higher that risk becomes. So with colon cancer, if you have one first-degree relative, and that means child, sibling, or parent, then you have approximately a 10% risk with one first-degree relative of developing colorectal cancer. That's compared to the average lifetime risk of 5%. Now, if you have one first-degree relative who was less than 50 years old when they were diagnosed, you have around a 15 to 20% lifetime risk of developing colorectal cancer. And as you can see, that will jump up quite a bit if you have two or more first-degree relatives. You can have even up to a 50% risk of developing colorectal cancer in your own lifetime. Now, there's inherited conditions such as Lynch syndrome or familial adenomatous polyposis, also known as FAP, and those are going to significantly increase your lifetime risk, and we will talk about those a little more in the end of this presentation as they're more rare. But often when patients come to see us and they talk about a family risk, the main thing we are looking for is first-degree relatives. Now, having a cousin or a grandparent that has had a history of colon cancer overall does not really change your risk compared to the average risk. So we do often have people who will say, my grandfather, my grandmother passed away. At that point, you do still stick with the routine screening and the routine risk because it's been shown this increased risk really is for first-degree family members. Now, if you have multiple second-degree family members or very few first-degree family members to compare to, we may risk stratify that individually. But overall, when we talk about an increased risk, we really mean your first-degree relatives. And as you can see, as you hit more of those first-degree relatives or younger first-degree relatives, your screening intensity is going to go up. So beyond demographics, other risk factors include lifestyle, which includes obesity, low physical activity, smoking, and moderate or excessive alcohol use. And then additionally, diet, including high diets in red or processed meat, particularly pork, beef, bacon, those sorts of things. Low fiber containing foods, low fruits and vegetables, charred, broiled, or grilled foods, and additionally ultra-processed foods. But the biggest risk factor is failure to get screened. As we stated earlier, colorectal cancer is quite lethal, and there's 50,000 Americans every year that die from colorectal cancer, so about 8% of all cancer deaths. In Colorado, that number is close to 700 Coloradans will die every year from colon cancer, so quite a few even in our own state. So just very important to know your own risk and be as informed and as updated as you can with your screening. So looking at colorectal cancer staging, one thing to remember is that we've highlighted that early detection of polyps is key. So if we can catch a polyp before it becomes a cancer, that's the best way to prevent this. But it's also important if you do catch a colorectal cancer to try and catch the cancer as early as you can too, primarily before it metastasizes or spreads to other organs. We stage colon cancer, as most other cancers are staged, from 0 to 4, 0 being the least invasive, 4 being the most invasive, 4 meaning it has metastasized or spread to other organs. And if you do end up having stage 4 or metastatic colon cancer, the average 5-year survival at that rate is less than 5%. So that does show that colon cancer, if it's not found early, is one of the more deadly cancers. And as we can see on this slide too, if you find it at stage 1 or stage 2, your 5-year survival is anywhere up to 95%. So we really want to catch things as early as we can. So this slide is highlighting which of the modifiable risk factors exist, and those include lifestyle and diet. These ones are what we call modifiable risk factors. We can't change your age, your sex, your family history, but we can change lifestyle and diet. So we know that being overweight and not being physically active have both been linked to colorectal cancer. Additionally, diets that are high in red meats, particularly beef, pork, lamb, or liver, along with processed foods like hot dogs, lunch meats, bacon, will increase your colorectal cancer risk. Typically, people ask me which diet is the most recommended diet to help prevent colon cancer. A diet that's high in fiber, such as a plant-based diet, or the Mediterranean diet, which is also a very heart-healthy diet. Beyond diet, people who have smoked tobacco are more likely to develop and die of colorectal cancer compared to those who don't smoke. And moderate to heavy alcohol use is also another identifiable modifiable risk factor for colon cancer. We recommend limiting alcohol use to less than 2 drinks per day for men and 1 drink per day for women. Now, there are, in theory, some protective factors for colorectal cancer too. One that's been more heavily advertised has been aspirin for select groups. So there's been studies that have shown that people who regularly take aspirin may have a lower risk of colorectal cancer and polyps. However, we don't recommend aspirin for the sole purpose of trying to prevent colorectal cancer. If you're already on aspirin from the direction of your healthcare provider, it may give you that added benefit, but just starting aspirin is something to consider that has risk as well. It can cause serious or even life-threatening side effects such as bleeding from the stomach or stomach ulcers, and that in general will have the benefits not really outweigh the risk for the general population. So you should always talk to your doctor before you start anything, particularly if it's for screening. And then by far the most protective risk factor is screening. So as we stated previously, prevention and early detection are the most important. So we will now go through some of the screening modalities that can be used, which include stool-based test, endoscopic visualization, and radiographic visualization. So stool-based testing would be testing that involves providing a stool sample, and that one is going to be identifying cancer, versus prevention, which is imaging, including or endoscopic polypectomy. To begin with the early detection stool tests, there are 3 types of stool tests that are available. These include the fecal immunochemical test, also known as the FIT test, which is looking for blood in the stool, the guaiac-based fecal occult blood test, and then additionally the multi-targeted stool DNA test with FIT, which is also known as the Cologuard. If any one of these tests become positive, it's very important to know that the next step will be a colonoscopy, so this potentially could be a 2-step test if you have a positive FIT or Cologuard. It's also important to note, and a question that we get a lot, if you have had a positive Cologuard, for insurance purposes, the Cologuard counts as your screening, and a colonoscopy will then become diagnostic, so it will not be fully covered by insurance if you start with a stool-based test. So if you have a positive, you may end up paying for a second test or partially paying for it, given it is no longer a screening at that point. The guaiac-based fecal occult blood test will test for hemoglobin, or blood in the colon. So this test will see if there's blood in the stool, which can be from many things, including a polyp or cancer, but also could be from hemorrhoids, upper gastrointestinal causes such as stomach ulcers, or even sometimes just trauma from, if you had it with a rectal exam or with a stool. For the fecal occult blood test, you have to do 3 consecutive stool samples, since not all polyps can bleed and some can escape detection. So if you're going to do the fecal occult test or the FOBT, that is 3 stool tests. The next type of stool test is the FIT. That's the fecal immunohistochemical test. And this requires one stool sample. It does not require you to restrict or change any medication or diet prior to providing your stool sample. There are some limitations to the FIT, including less sensitivity to detecting right-sided polyps or cancer compared to left side. So the right side is going to be that cecum and ascending colon compared to the left, which was the descending and the sigmoid, if you recall from our earlier diagram. Now, the most common stool-based test in the United States is the multi-targeted stool DNA test with FIT, also known as the Cologuard test. This will test for DNA mutations associated with colorectal cancer, but also includes the FIT portion looking for hemoglobin or blood in the stool. This again is one stool sample, and it's one full stool sample provided to complete this test. And this is just some photos of what these may look like. The left is going to be the Hemocult test, which is the FOBT, which is 3 samples. The FIT test is the center top photo, which is 1 sample, and then the bottom is the Cologuard. So these are the non-invasive assessments for DNA and or blood in the stool. So these are all going to be mailed in, and you really usually only get 2 results. Every now and then there will be an indeterminate, but typically you will get a negative, which means there's no blood or DNA detected, pending which test you did, or a positive, meaning there is blood and or DNA detected, depending on which test you did. And again, a positive of any of these means the next step is a colonoscopy. Now, something to think about here with the Cologuard, and then also the FIT testing, is how high quality these tests are. So the FIT fecal DNA, which is the Cologuard test, will find about 92% of cancers that are present in the colon. So it's going to miss some cancers. Now, it is only going to find about 42% of higher risk polyps, which is polyps that are greater than 1 centimeter or polyps that maybe have more advanced pathology. And those are the ones that we worry about turning into colorectal cancer. So it can miss quite a bit of these, as well as even the more small, typical tubular adenoma polyps. Those are not going to be picked up with the Cologuard. Additionally, the Cologuard has about a 12% false positive rate. So it can cause some anxiety getting a false positive. You have your colonoscopy and you wonder if it ever really was anything in the colon, but it does have about a 12% false positive rate. So overall, this will miss about 1 in 13 cancers. The FIT testing, which is the once a year hemoglobin-based testing, will find approximately 75 to 80% of cancers that are currently present, so also has a higher miss rate. It will find only about 30 to 40% of high-risk polyps, so those polyps that are the ones that we worry the most about progressing to colon cancer, but it has a lower false positive rate than the Cologuard. It has a less than 4% false positive rate. Overall, this will miss about 1 in 5 cancers. Now, the colonoscopy, which is the gold standard for colorectal cancer screening, will find 95, possibly more than 95% of colon cancers. And as you can see in some of those earlier slides, some of those really flat, more sessile lesions are the ones that we cannot see, pending what the colon is doing. The colon is very mobile during exam, or the quality of the prep. So while it is not 100%, it is by far the highest. It will find and remove over 95% of higher risk polyps and average risk polyps. And there really aren't as many or any false positives with the colonoscopy because we're getting tissue and we're letting you know exactly what we found. Now, there are cancer miss rates, so about a 0 to 6% chance of interval cancers, meaning cancer between colonoscopies. And often that's from polyps that were not seen, again, due to what the polyp looked like, the quality of the prep, or just what was going on with the colonoscopy that day. So now moving on to the prevention-based colorectal cancer screening, which includes imaging and then colonoscopy. So as I said, colonoscopy is the gold standard for colorectal cancer screening and detection of precancerous polyps. The colonoscopy procedure is a little bit more involved than the stool-based testing. So this will require a bowel prep and a clear liquid diet the day before the procedure. The day of the procedure, typically you are given an anesthetic, so you will need a ride to and from the endoscopy center. That's so that you can be asleep during your exam and remain comfortable. Once you're asleep, a flexible camera with a light on the end will then be introduced through your anus and taken around the entire colon. As I stated earlier, a colonoscopy will look at all 4 to 5 feet of your colon and will get to where your small bowel and your large bowel meet. The cecum is the extent to which the colonoscope is inserted, and then the scope will be withdrawn and we will inflate your colon with air so we can try and make it as large as we can to reduce the risk of missing anything behind any folds. Now, if a lesion is found, it will then be biopsied or removed during the procedure, making this a one-step procedure, so you won't have to come back and have anything removed, such as if you had a positive Cologuard or FIT. Beyond a colonoscopy, like I said, there's also imaging-based testing, and that it means a CT colonography. So a CT colonography involves obtaining multiple thin-sliced computed tomography data and using computers to construct 2D and 3D images of the colon. Now, one thing with a CT colonography, it does also require a bowel prep because the CT scanner needs to be able to see as much of the colonic wall as you would have to have during a colonoscopy. You then will have air introduced into your rectum to inflate the colon, similar to what a colonoscope would do during a colonoscopy, to look at polyps or cancer. Now, similar to the stool-based testing, unfortunately, if there is a positive result, the colonoscopy will then be recommended, so you may again have to do another bowel prep and do a colonoscopy. Now, for the CT colonography, finding polyps under 6 millimeters or 1 centimeter is less likely, so it's usually only going to find larger polyps, but that is one thing that the stool-based testing had a lower sensitivity rate. They don't find as many compared to the CT colonography. And then with the CT colonography, there is also the risk of radiation, so something to consider when you are considering doing a imaging-based test. And this is just a photo of one of our endoscopic tools. This is known as a snare, and this snare will have a little serrated lasso that can open up and go around the polyp and then cut the polyp off during the exam. And during a CT colonography, this is the picture that the CT scanner will create, making a 3D image. And as you can see, if it finds a large lesion, it will map out where it is and roughly how big it is and what it looks like. So colonoscopy quality can be very effective, but it does have some factors that are up to the patient. One of those is split dose prep. So in previous years, this was not as common as it is now. A split dose prep means you drink half of the prep the evening before your colonoscopy, and then you drink half of the prep the morning of or 4 hours before your colonoscopy. That's because even overnight, your bowel will be making stool, and so that second half of prep will make sure that anything that was created while you were sleeping is then cleaned out. As you can see in the photos at the top right of this slide, an excellent prep makes it much easier to see polyps, see anything irregular in the colon. And as you move to the right down this slide, you can see how much more difficult it is to see if there's some liquid or some stool obscuring the bottom portion of your colon, or if there's more solid stool that's stuck to the walls of the colon, really hindering and making the exam ineffective. Now, good compliance with instructions will make an exam much more effective, and that includes a low residue or a low fiber diet a couple of days prior to the exam. Low fiber foods will move through your colon faster compared to high fiber foods, so that's why we have you do a low fiber diet before you start your prep. Additionally, avoiding constipation prior to starting prep is also very helpful. So if you are someone who is more prone to constipation, that's something you may want to discuss with your scheduler, since we can make some modifications, meaning maybe a longer low fiber diet or adding some Miralax doses in the evenings the week leading up to your bowel prep. It's also very important to read the instructions carefully. The instructions can be difficult. I have read them and I've gone through them with people in my family. But if you read through them carefully, they can give you all the information you need. And at our group, we always do have a hotline 24/7 where you can call with questions if something is unclear. So, as we stated, colonoscopy is the best form of prevention. It is the most effective colorectal cancer prevention test. It detects 3 times more advanced lesions than the FIT test, 2 times more advanced lesions than the FIT DNA test. It is the only test that is a single test with diagnosis and resection. And it's also the only test that has been approved to be performed at 10-year intervals due to the high accuracy of the test. Now, colonoscopy is not risk-free, so there are always things to consider for your own individual risk of which type of screening modality you want to pursue. With colonoscopy, there's a less than 1% risk of cardiopulmonary events. Typically, these are related to anesthesia, but can be related to the stress of the exam as well. Often, these are in patients that have pre-existing cardiac or pulmonary conditions. So again, very important to let your scheduler or your doctor know, and we can modify as much as we can and potentially even do your exam in the hospital to be as safe as possible. Additionally, there's about a 0.3 to 0.7% risk of perforating or tearing the colon. Now, the standard of care is considered about 1 in 2,000, so 0.05%. And if you've seen someone out there who says they've never had a perforation in 20 years, that's not really the standard. These will happen. It is our most dreaded complication, but if you do enough colonoscopies, this will happen to you sometime in your life because there are complications that happen, there are difficult exams, there are large polyps. Additionally, the next risk we usually discuss is bleeding after polyp removal. This happens about 0.5% of the time. So I tell all of my patients that taking out polyps does create some bleeding. That is normal. We're pulling something or cutting something away from the colonic wall. Most of the time, this bleeding is going to stop before you leave our endoscopy center, but in that 0.5%, bleeding may continue. There's lots of factors of why this may happen. If it's a very large polyp, then it's a higher surface area where bleeding can continue, or if there happened to be a blood vessel underneath or around where the polyp was, that increases the risk as well. Now, if there is a post-polypectomy bleed, we can repeat a colonoscopy and often stop the bleeding ourselves. But additionally, things like surgery or interventional radiology intervention may be potentially a possibility. In general, death attributed to colonoscopy is about 1 in 15,000. This is usually very individual based on someone's personal risk factors, why we're having the exam done, what previous exams have shown. And just to put that in perspective, lifetime odds of death for much more common causes of death, it's about 1 in 100 for a motor vehicle accident, 1 in 102 dying from a fall, 1 in 221 dying from a gun or a shooting. That number may be different now, or about 1 in 1,024 dying from drowning. So overall, compared to the more common causes of death, very, very low chance that will ever happen in a colonoscopy. So as we alluded to a little earlier, the quality of the colonoscopy has improved quite a bit from previous decades, and there are certain things that can make your colonoscopy quality better, so it's important to be informed on when you're choosing where to go and who to see. An expert who is experienced with colonoscopy and takes the time needed to find and effectively removes polyps is really the place that you want to go. High definition colonoscopes, so the scopes that have been developed over this past several decades, are much different than older colonoscopes, so you want to make sure you are going to a center with high definition exams. Additionally, the most important thing is a careful exam of the entire colon. So all gastroenterologists have a standard of at least 8 minutes on withdrawal. So once you get to the cecum, pulling the camera out, which is when we really do examine the colon, needs to take at least 8 minutes. Most people are probably taking closer to 10. So if people are only in there for a couple of minutes, they're not getting a good look. You want to make sure you have an experienced endoscopist. Greater than 95% cecal intubation rate, meaning the colonoscope gets all the way to the end of the large bowel, where the large bowel and the small bowel meet. Whoever is doing your colonoscopy should be having that happen over 95% of the time. Not everyone is going to be able to have a full colonoscopy. Sometimes anatomy is just too difficult, and that's why that number is not 100%. Additionally, having an endoscopist who has a high adenoma detection rate, which means how many polyps per patient they are seeing. So the lower acceptable end is greater than 20% for women or 30% for men. And just in the United States, the average adenoma detection rate is close to 40%. Now, this is a study that was published in the New England Journal of Medicine in October of 2022, and this is one that people have asked, is colonoscopy effective or ineffective? So I want to talk about it a little bit more since it's been brought up from other practitioners as well as patients. So 85,000 people in Norway, Poland, Sweden, and Netherlands were looked at. They were looked at with one colonoscopy versus no type of screening. This was a randomized from the population. There was no primary care involvement, no advertisement, and they were sent a single letter inviting them to be screened. The primary endpoints of the study were looking at colorectal cancer incidence and mortality after 10 to 15 years and all-cause mortality. Something to think about with this, 1/3 of the endoscopists had an ADR less than 20%, which is below the minimum acceptable standard in the US. Again, in the US, it's closer to 40%. Now, this study showed there was a risk of colon cancer was 18% lower in the group invited to undergo screening. It stated there was no decreased risk of death overall, which is where people are asking, is colonoscopy effective? So, as with anything that you read, you have to think about the limitations of the study. So only 42% of those invited actually had a colonoscopy. So all of them were invited to be included in the outcome analysis. So, 58% did not have any sort of screening. Of those who actually had the colonoscopy, of those 42%, 31% had a reduced colon cancer risk and 50% reduced risk of death. Additionally, this study had too short a follow-up period. It was only actually 5 years, so really not long enough to see benefits of polyp removal over time. And overall, it really did show that colonoscopy worked for those who had it, and it works better when it's done well. So that's where that adenoma detection rate and the quality of the exam is important. At Gastroenterology of the Rockies, we do also have something called GI Genius. So I think everyone knows that AI is becoming more and more prevalent in day-to-day life. I think it's hard to go anywhere without ChatGPT being brought up nowadays. But AI is also available in the medical field, and in GI, one AI advancement is called GI Genius. So this is an artificial intelligence, which is a little computerized box that is connected to our tower where our colonoscopes and endoscopes are plugged in. It will then be connected to the interface that projects the screen, which has the camera visualization of what the colonoscope is showing. As you can see in this photo, it makes a little green box around what it believes to be a polyp or a piece of abnormal tissue. There have been studies showing that it improves ADR and cancer detection about 13% in randomized controlled trials. So it's increased it from 42 to 55%. Now, I think it's important to note it's been shown to help find tubular adenomas or adenomatous polyps. It has not been shown to be significantly helpful with those flatter lesions, those sessile serrated lesions. So while it definitely is helpful, it does also have its limitations. So moving on, we want to talk about risk groups. So history is very important when discussing colon cancer screening. So when you're talking to your primary care physician or your gastroenterologist, we do need to get some information in order to accurately risk stratify you. A patient is only considered average risk if they have no personal or family history of colon cancer, as well as personal history of polyps or even family history of polyps pending the age. Additionally, a personal history of inflammatory bowel disease, such as Crohn's or ulcerative colitis, mean you are above the average risk. In general, the patients who are average risk will start colorectal cancer screening at age 45. Then typically we'll stop around age 75 to 85. When you hit 75, it's an individual discussion with yourself and your practitioner. And then around 85, most guidelines will recommend stopping unless there's been a significant personal or family history, as the benefits and the risks start getting a little more skewed towards the risks at that age. The options for screening include an FOBT, which is that 3-time stool test looking for blood in the stool, and a FIT. That is annually. The FIT DNA, or the Cologuard, is every 3 years. A flexible sigmoidoscopy, which we didn't talk about too much, but essentially is a shorter version of a colonoscopy. It only looks at the left side of the colon, so the rectum, the sigmoid, the descending colon, is an option that's available every 5 years. I personally do not recommend this to patients because it's not looking at, half or more of the colon, and it's not doing any stool-based testing to look for blood on that half of the colon as well. So in general, again, it's something individual, but that is not a great option. Then the CT colonography, which is available every 5 years, and then colonoscopy, which can be every 10 years, pending what is found in your risk. If you do perform screening, colorectal cancer cases and death can decrease by 60 to 80%. So again, prevention is key, and doing some kind of screening is best compared to doing no screening. So the United States Preventative Services Task Force, or the USPSTF, in 2016 recommended colorectal cancer screening at age 50 years and continuing to 75 with multiple modalities to choose from, and then individualizing screening from ages 76 to 85. Now, this was a task force that was used to make evidence-based recommendations about the effectiveness of clinical preventative services. And like we said, prior to 2018, they recommended everyone start screening at age 50. However, around that time, 2017, repeated modeling studies were showing incidence and mortality were increasing for the young. So with that, starting at age 45, we were seeing a 4 to 8% decrease in number of new colorectal cancers, and 8 to 11% decrease in colorectal cancer deaths, with 12 to 17% increase in number of colonoscopies needed compared to those starting at age 50. So in 2021, the USPSTF recommended offering colorectal cancer screening starting at age 45 and continuing to age 75 using whichever screening strategy you choose, and then individualized screening, having that risk-based discussion with your practitioner from ages 76 to 85. And then the American Cancer Society actually in 2018 had recommended 45 and older undergo colorectal cancer screening. So it took a few years for the USPSTF guidelines to catch up, but now for the past 4 years, 45 has become the new 50, and all screening should begin at age 45 for the average risk patient. Now moving on to the risk groups, not everyone is going to be told to get their colonoscopy or their colorectal cancer screening at age 45. Increased risk, as we talked about those with a family history of first-degree relatives, will start either at age 40 or earlier, depending on the age of the colorectal cancer in your family. Now, the oldest you should be if you have a first-degree family member with colon cancer is age 40, but the other rule is 10 years younger than your diagnosed family member. So if your family member was 56, you would start at age 40. because the oldest you should be is 40. But if your family member was 46, you would start at 36, which is 10 years younger. So it's 10 years prior or age 40, whichever comes first. Also, for those who are increased risk, you're not the average risk anymore, so we do recommend colonoscopy versus those stool-based tests, as those are recommended for average risk patients. Additionally, there's hereditary syndromes, which we'll talk very briefly about later on, and those may start much earlier, such as age 12 to 25, and may include an annual colonoscopy. So family history is a risk factor for colorectal cancer. Cancer tends to occur at an earlier age with family history, and on average, patients with a family member with history of colorectal cancer develop cancer approximately 10 years earlier than their family member. So that's where that 10-year number comes in. So 10 years prior or age 40. So of the colon cancers that are found, about 70% are sporadic, but there are other familial and hereditary causes of colorectal cancer. Now, hereditary refers to a disease with a known genetic cause, and then familial appear to have a genetic cause and effect towards family members that would be more than by chance alone. Now, sporadic colorectal cancer, as I said, is still the most common form of colon cancer, accounting for about 70%. When there is a familial implication, that's about 25% of colorectal cancers. And those hereditary causes, primarily Lynch or familial adenomatous polyposis or FAP, are only about 1 to 3% combined. And those will require more special attention as they are going to have much more stringent guidelines for screening. Now, for Lynch syndrome, this is an autosomal dominant condition, meaning that if your family member has it, it's a higher chance you are going to have it too. It's only about 3% of colorectal cancers, but your colorectal cancer risk, if you have Lynch syndrome, is about 50%. Typically, if you are to get colorectal cancer with Lynch, it's going to be a much earlier onset. Average is about 44 years. It's typically a proximal location, which means that right side of the colon, so the ascending colon, the cecum, the part of the colon that's closer to the small bowel. Lynch syndrome is also associated with other cancers, including uterine and ovarian cancer. Lynch syndrome overall requires genetic testing, MMR genetic testing, to see if you have the condition. It is under-recognized. It's only less than 5% of the population. One thing to note with Lynch syndrome is screening does work for Lynch syndrome. You will begin getting an annual or an every other year colonoscopy starting at age 25. Now, the other hereditary condition is familial adenomatous polyposis, which is even more rare than Lynch syndrome. So it's about 1 in 7 to 22,000 individuals will have FAP. Like Lynch syndrome, it is autosomal dominant, so if it runs in your family, it's a high chance that you will have it. It's also genetic testing, and you want to get this tested very young, since if you do have FAP, you're going to start having screening around age 12, and you're going to have annual surveillance. Oftentimes, patients with FAP will have a colectomy, as the colorectal cancer risk is approximately 100% in these patients. So sometimes preventative removal of the colon does happen. So to summarize, colorectal cancer is about the third or fourth most common cancer in the United States and second most common cause of cancer death. It's a sequential progression from polyp to cancer. It is lethal. It's strongly dependent on what stage it is found, the lethality of the disease, but overall it is lethal. And it's very preventable. Lifestyle changes can make a big difference, but screening is the most effective prevention to implement that early detection strategy. Familial and hereditary colorectal cancer requires special attention, so always bring that up with your physician or your practitioner. And then the biggest take-home points here are colonoscopy can prevent colon cancer. Start at age 45 if you are average risk. If you don't know if you're average risk, ask your doctor. Only test that's recommended for a positive family history. So if you have first-degree relatives or hereditary conditions like Lynch or FAP, you will be recommended a colonoscopy rather than stool-based testing since you're no longer average. If you're average, it's every 10 years, but can be sooner, pending if you've had adenomatous polyps found, a personal history, or a family history of colon cancer. And like I said several times, please let your doctor know about your family history since it is really important to risk stratify you. Everyone is individual and not everyone can or will get a colonoscopy, but there are other screening methods available. So always consider the FIT, which is yearly, or the Cologuard, which is the FIT fecal DNA every 3 years. Just with the caveat knowing this can miss some cancers and many high-risk polyps, and it may be a 2-step test. But as we've shown, having screening of any modality is much better than no screening. All right, thank you very much. And if there's any questions, I would be happy to address these.
Thank you so much for the lecture tonight, Dr. Zucker. We have received some questions already. We want to remind our audience at this time that now is the time to submit your general question in the chat box below the video, and we will take as many as we can tonight. They're in no particular order. How does being type 2 diabetes affect the colonoscopy prep? Is there anything to take so that your blood sugar doesn't drop too much?
So this is a question that we do get asked quite often. So if you are a type 2 diabetic, overall it does not change which prep you will be given. You will still get the normal prep. You will still have the normal fasting. Now, the day before your colonoscopy, you won't have any solid food, but you still will be able to have liquids. So jellos, juices, popsicles, all of those are still available, clear liquids up until even 3 hours before your exam. So you will still be able to have sugar intake, so your blood sugar will not drop too dramatically. Additionally, sometimes we'll have you hold certain diabetes medications, particularly things like Ozempic, those GLP-1 medications, so that you have less GI side effects, but also for your blood sugar. So if you have type 2 diabetes, make sure you let your scheduler know and let them know which medications you're on so we can hold them if needed to help prevent those risks. But you will be able to eat, you will be able to have sugar-based foods. It will just be in a liquid form.
Okay. So when you're performing a colonoscopy and you remove a polyp, how do you know if you've removed the entire thing?
So how do you know if you've removed the entire polyp? So that's several ways we can tell. One, we can tell visually. So those polyps that have a stalk or polyps that are a little more raised off of the wall of the colon, we can visually see that we have removed them. Additionally, with our snares, we'll put an area around to take normal tissue as well as the colon polyp to ensure we've gotten all the margins. Besides visually seeing if we've removed the polyp, we do send the polyps off to pathology, and they often can remark on the borders to say if there is still polyp present at the border or if there is no polyp present at the border. So we have a two-phase method to know if it's been removed fully. I will say with that, sometimes if you have a particularly large polyp, that can be hard to say because we can take those polyps out in several pieces. It's called a piecemeal removal. And in those cases, the pathologist often will not be able to tell, and it may be a little bit more difficult to tell endoscopically as well if the whole polyp has been removed. So if you're someone who has had a piecemeal removal, typically your gastroenterologist will recommend a 6 to 12 month follow-up to go back and reassess that site to ensure no polyp has been left and nothing has grown back.
But in the piecemeal removal, you can do that procedure during the colonoscopy?
We do that during the colonoscopy, yes. So yeah, if you have a particularly large polyp, it still will be taken out during a routine colonoscopy. You just may have a more soon follow-up to ensure it's been removed. But an average polyp, meaning a polyp less than 1 centimeter, we can typically tell just visually that it's been taken out.
Okay. Given that catching it is so important, why then is 10 years recommended? Is colon cancer really that slow growing?
So yes, 10 years is recommended based on the average rate of a tubular adenoma to grow to be large enough to have dysplasia or colon cancer. And it's been shown that takes about 10 to 15 years for a routine polyp. Now, if you've had a more aggressive polyp, such as a tubulovillous polyp or a sessile serrated adenoma, those grow a little bit faster, in which case you will often be provided with a shorter screening interval, such as 3 or 5 years. So if you've had a history of polyps, we'll stratify that based on your kind of polyp. But if you've had no polyps, you get the 10 years, since that is the average time it takes for a polyp to become a cancer. Most honestly take more than 10 years, so having a colonoscopy every 10 years with a normal exam is usually still finding things very early, when there's still a polyp before they become a cancer.
So I think you've answered this, but I'll ask it anyway. If someone has a normal colonoscopy at age 50, is it okay to wait until age 60 to get the next one?
Yes, if you've had a normal colonoscopy at age 50, it's fine to wait until 60, as long as you have not personally had a history of polyps or a family history of colon cancer in your first-degree relatives.
Okay. And then what is the age that you normally recommend stopping the colonoscopy?
So all guidelines recommend stopping around 85. Now, in between ages 76 to 85, that is going to be individual based on if you have had a personal history of polyps or a personal history of colon cancer or a family history of colon cancer. So if you've had completely normal examinations from age 45 to 75, typically we will tell you to stop at 75 rather than wait until 85 and get it then. But if, say, you've had a couple polyps every colonoscopy you've ever had, we often will keep having you continue colonoscopies until 85. So it is individual, but all guidelines stop at 85.
Okay. So do you know why someone who is just 80 years of age would be denied a colonoscopy despite the fact that they have an immediate relative with colon cancer?
I do not know why that person would be denied. If they've had any other significant medical history, if they've had significant cardiac history, significant pulmonary issues, the risk and benefit ratio may be more skewed toward risk. But without knowing that patient, knowing their medical history, I cannot give you that exact answer.
Okay. This person has a twisted colon. So during their colonoscopy, the doctor couldn't go all the way in. They do have a family history of colon cancer. 5 years ago, they did have a polyp as well. What do you recommend as the next step?
So someone who has a very tortuous colon, which I do see a lot of since women have more tortuous colons and I primarily scope women. Sometimes they can get so tortuous, so twisty, we can't get the camera through. We do have limitations with our colonoscopes. If you've had a family history and you have a history of polyps, I would then recommend a CT colonography in that case. That's the only other test besides colonoscopy that will actually give you a visual representation of the colon. And then if there is anything large seen and you can't have a colonoscopy, then an option potentially could be surgical resection of that area, since the CT will show you where a problematic spot may be. So my recommendation would be to get a CT colonography in that case. And if I do have a patient that I cannot get through their colon, which as we said does happen, I typically will recommend a CT colonography next.
Okay. This person had a colonoscopy around age 50. They've used Cologuard since that time. Do you think that their primary care should recommend a colonoscopy, and are they covered by Medicare?
So I'm going to be biased. I recommend everyone get a colonoscopy. I think colonoscopy is by far the most effective test that is out there for colon cancer screening. So if you've had no family history, no personal history of polyps, in theory you are a candidate to have the stool-based testing, the Cologuard or the FIT. But if you're someone who wants to be more proactive, more preventative, I highly recommend pursuing a colonoscopy rather than the stool-based testing. Medicare does cover colonoscopies as a screening test. I will say with Medicare and with almost all insurances, they will only ever cover one screening test per year, or whatever the interval of the guideline that you got. So if you got a FIT test, you can't get anything for that year, but you could get a colonoscopy the next year. If you got a Cologuard, you would have to wait until the Cologuard limit is up, which is 3 years, and then you could have a colonoscopy. So if you wanted to switch to a colonoscopy for your next screening, I would highly support it. I'd be happy to see you.
Okay. Regarding family histories, do only colon cancers count, or are any other kinds of cancer a concern?
So primarily only colon cancers. When we talk about that increased familial risk, we're talking about colon cancer. Now, if you've had a strong family history of some of the cancers associated with Lynch, which is primarily breast, ovarian, uterine, those may warrant you getting tested for Lynch syndrome. But in general, when I'm talking to a patient, I'm talking about colon cancer, since if they have Lynch or FAP, they've usually gotten genetic testing before they've seen me.
So another question about family history. Someone, their mom passed at age 89. It was suspected colorectal cancer. Should that person include that in their medical history then?
Yes, yeah, you should let us know that. When we talk about colon cancer and the increased risk, we usually talk about younger age, age 50 or less than 65, but I am a little bit more conservative in my own practice, and any first-degree family member in my mind would warrant sooner and more frequent screening.
Okay. How does inflammation in one's colon impact the risk of developing colon cancer?
So in that case, the inflammation that would increase your risk would be inflammatory bowel disease, which would only include Crohn's or ulcerative colitis. Now, those with Crohn's and ulcerative colitis do have a largely increased risk of colon cancer, particularly if the inflammation is uncontrolled. So if you're not on therapy for your inflammatory bowel disease. Those screening guidelines are going to be different, and that's a very complex topic since it's a very systemic and difficult disease to manage, IBD. But typically you're going to have a colonoscopy every 2 to 3 years if you have ulcerative colitis or Crohn's due to your increased risk.
This person has had polyps every time they go and get screened. And so first it's
You're not alone.
At first it's been 3 years. It's been 3 years for the past 15 years. Their mom had colon cancer. They found it with her mom at age 72, but she lived till she was 94. Now the doctor is recommending that instead of 3 years, that this person goes every 5 years. Do you know why?
So if you had no polyps or only 1 or 2 polyps on your most recent exam, then your guideline would change to 5 years. As we've said, polyps in general take 10 plus years to become a cancer. So with a family history of 5, you should be getting most polyps relatively early. And the 3-year recommendation comes on the number or the size of polyps. So if your last exam didn't have very many or had very small, then 5 would be the standard to go to next.
Thank you for clarifying that. Should the finding of a sessile serrated adenoma be of concern?
So I wouldn't say it necessarily is of concern. So it's one of the types of polyps that we are looking for to remove. One thing with sessile serrated adenomas, they are the flatter lesions, so they're a little bit harder to find. They also can spread laterally and grow a little bit faster. So if you have a history of sessile serrated lesions, even if you only have 1 or 2, you would be advised to come back at 5 years rather than a tubular adenoma, which would maybe be 7. So you may have just a shorter interval, but just having them and having them removed overall is not significantly concerning.
Okay. We have time for just a few more questions here.
Okay.
This person's mother developed stage 4 CRC in between 5-year colonoscopy screenings. How common is this?
That's not that common. As we stated on one of the slides about quality of exams, there's a 0 to 6% chance of interval colon cancers being found between colonoscopies. Some colon cancers really do just grow more aggressively, so having something develop in 5 years is unlikely but not unheard of. Or it could have been one of those smaller flat lesions that was missed and then it had 5 more years to develop when it typically would have been removed. Or if there was a problem, with bowel prep, or if the exam was particularly more difficult, it may have made it harder to find something at that time. Now, once cancer has, grown into the colonic wall and it's no longer just a superficial cancer, it does grow much more quickly. So you can go from, stage 2 or 3 to 4 pretty quickly because cancers divide very rapidly.
Can you please explain the cardiac risk you mentioned?
So the cardiac risk is typically, with anesthesia. The anesthetic is going to, this may be something that's better for an anesthesiologist to answer, but it is going to, suppress your blood pressure a little bit, suppress your heart rate, and you are going to be under some stress from the exam. So in that case, if you're someone who has had a significant history of heart attacks or coronary artery disease, you may have slightly decreased blood flow, and that can increase your risk potentially of a stroke or a cardiac event if you've had that personal cardiac history before. Now, overall, that's very, very rare. It's one of the questions that we ask all of our patients beforehand, and if you do have a significant cardiac risk, we typically will talk to your cardiologist as well to see if they think you are safe for anesthesia prior to proceeding.
Will you personally perform colonoscopies without any sedation? This person has had 2 without it.
If someone has had a successful colonoscopy in the past with no sedation, then I will sometimes say yes. In general, I do prefer patients to have sedation because I think that it's more comfortable for you. It's also been shown to be safer for the endoscopist because even if you're trying your very best to relax, if you clench or tighten your abdomen involuntarily, which everyone does when they're uncomfortable, it increases the risk of tearing or perforating the colon. But if you've had 2 prior no sedation colonoscopies and you've had no trouble, then I would definitely consider doing your colonoscopy, yes. I did a no sedation colonoscopy today, in fact, on someone who had done one previously, and he did very well. So.
Okay, good to know. Would your abdomen hurt after you eat if you have colon cancer or polyps?
Your abdomen typically will not hurt with polyps. Polyps in general are asymptomatic unless they become very, very large. Now, having your abdomen hurt right after eating with a colon cancer is not common because typically it takes, 12 plus hours for food to enter the colon and start turning into stool. It's more common that you're going to have pain, many hours after you eat, or a kind of a constant dull pain, or pain when you're having a bowel movement. So right after you're eating is very unlikely to be a colon cancer.
Okay. Thank you very much for answering those questions, but we have come to the end of our time.